Good morning, everyone. It's my pleasure this morning to introduce our opening plenary speaker for today, Dr. Brooke Cunningham. In January 2023, Dr. Cunningham was appointed the commissioner for the state's lead public health agency, the Minnesota Department of Health, where she oversees the work of 1,400 employees, all working together to protect and improve the health of Minnesotans. In this role, Dr. Cunningham clearly has demonstrated her leadership as well as her commitment to the well-being of all Minnesotans through her efforts to advance health equity for all. Prior to her appointment as commissioner, Dr. Cunningham served as the assistant commissioner for the Health Equity Bureau at the Minnesota Department of Health, where she led crucial initiatives focused on health equity, including the Center for Health Equity, the Office of American Indian Health, and the COVID-19 Health Equity Team. The Health Equity Bureau was created so that we could take a better look at the many conditions in people's environments that affect their health and create concrete plans to address them. Concurrently, Dr. Cunningham works as a general internist, sociologist, and assistant professor at the University of Minnesota. Her research focuses on reducing racial disparities in health, particularly addressing the adverse impacts of racism. Dr. Cunningham is also a primary provider at the Community University Healthcare Clinic, Cook Clinic in Minneapolis. Dr. Cunningham has a doctorate in medicine and a doctorate in sociology from the University of Pennsylvania. After completing residency in internal medicine at Duke University, she completed fellowships in health services research, health policy, and bioethics at Johns Hopkins University and Academy Health Delivery System Science Fellowship at the Medica Research Institute. She received her bachelor's degree in history and African American studies from the University of Virginia. Throughout her career, Dr. Cunningham has exhibited her passion for justice, equity, diversity, and inclusion. This is evident through her receipt of the JEDI Award here at the university, Minnesota's Justice, Equity, Diversity, and Inclusion Award, as well as her leadership at MDH that has demonstrated her vision for public health that centers on community and sees public health through a lens of health and racial equity. I explained that before I got started. I only had a couple minutes, so I definitely cannot do justice to all of the work that and the contributions that Dr. Cunningham has made to the field of public health. But let me just ask you to give a warm welcome to Dr. Cunningham and embrace the opportunity to learn about her knowledge, her experience, and leadership as we shape the future of public health in Minnesota and create a healthier and more inclusive society. Welcome. Thank
you. Good morning, everyone. It's good to be back on my old stomping grounds. I am on leave, but I was here last for that JEDI Award, so this room gives me a particular warm feeling, and I used to serve with Kiara on the Community Advisory Board, the internal panel for the Cancer Center. So I'm happy to be back in this role as commissioner. Again, I went to MDH from the U last March as they built their Health Equity Bureau out, and then when Commissioner Malcolm decided that she was going to retire, I thought long and hard and threw my name in the hat, and so got the job. And so I need you all's partnership, because you all know that Commissioner Malcolm has big shoes to fill. And so we need everybody in this room to support me, to continue some of her goals and to complete several of mine. So happy to be here today to talk to you all about cancer in Minnesota, about disparities in cancer, incidence, prevalence, and mortality, and really to hear from you. There are a lot of MDH folk in the audience. I gave them a hint, at least the folk who are at my table, that I might have to call a friend to answer some of the questions. And so to the extent that we can have some dialogue, even if it's comments, I really do learn and appreciate that part of any presentation. So, but again, first let me just say thank you. The work that everybody does in this room to address cancer, to alleviate disparities, to reduce its incidence and mortality is so important. And so we are here to work with you. Now, when I go into sessions, speaking engagement, I usually start off by really defining sort of MDH's spheres of control. So the things we have direct control over versus the things that we can influence. Direct control, we have control over data. That's really our jam, sort of data analytics, and a piece of my highest priority to make sure that we have 21st century data for a 21st century public health system, which for me means really thinking about social risk, right? And thinking about social risk beyond individualized social determinants of health. We also do convenings, we sponsor events like this, but we really try to work closely with networks of interested parties as well as clinics and community-based organizations around a series of health problems. We, of course, issue public health guidance to make sure that the provider community and the public are up to date about the latest health guidance. We regulate, of course, and we give a lot of grants out to community-based organizations, to clinics, folks who are our partners, to all of you. We don't provide direct care, which is what I usually try to lift up, but we do try to facilitate access to care and to close gaps through the very partnerships that I mentioned. So taken together, we are a bridge. We facilitate effective collaborations, we convene groups to identify common interests and create alignment and to foster action. We promote public health by translating health research and information into practice. We develop and disseminate innovative and effective cancer prevention and other health promotion strategies. And of course, we focus on priority populations, which for us at MDH are those who are disproportionately impacted by any health condition, in this case, cancer. So across all diseases, those who are disproportionately impacted tend to be those Minnesotans who have experienced and often continue to experience social marginalization and less access to opportunity in our state. So we focus on reaching those priority communities that experience barriers to health and work to reduce disparities across the state. So let me pivot to talk a little bit as a setup about data. And clearly, I'm not going to share statistics that many of you all are not familiar with, but let's just lift them up for a moment since this is a keynote. So we know that cancer is common. In fact, it is the leading cause of death in Minnesota. Personally, my father died of pancreatic cancer when I was 10 years old. Although he was young, cancer, of course, is more common in aging adults. Nearly 90% of all cancers are diagnosed in adults over the age of 50. Nationally, we are beginning to see increased incidence in those who are of younger age, especially in people of color. When we think about disparities, in Minnesota, African Americans and American Indians have the highest rates of both new cancer diagnoses and deaths. Overall, 4 in 10 Minnesotans will be diagnosed with a serious cancer in their lifetime. More than 300,000 Minnesotans are living with cancer, and men are more likely to die of cancer than women. So the good news, mortality rates, despite the increasing incidence, mortality rates overall have been decreasing over time, which again means the number of cancer survivors are also increasing. And as I'm in this conference, the other population of people that we can't forget to name are the caregivers of the patients who help with the daily tasks of living with a cancer diagnosis, but also the struggle of watching their loved ones battle cancer. So in terms of data, the Minnesota Cancer Reporting System collects cancer demographic data on Minnesotans diagnosed with new cancers from hospitals, clinics, and laboratories. This data can inform planning and decision-making at the local, state, and national level and foster research into the different cancers. And we think a lot about cancer surveillance and cancer data, cancer diagnosis, but I also do want to lift up that our environmental health program, as we sort of think about air quality, our environmental health program works with the Minnesota Cancer Reporting System to connect with Minnesotans who have concern about carcinogens in the environment, whether it's smoke or exposures to toxins in water. The Comprehensive Cancer Control Program works with partners across the state to plan and implement a coordinated approach to address cancer in Minnesota. including prevention and detection, treatment, survivorship, and end-of-life care. This comprehensive cancer control program supports the work of the Minnesota Cancer Alliance, which has brought us here today. So when we think about data and we think about cancer disparities, we know there's a lot of important work to do. When I move in groups, community groups in particular, about any health condition, there's a lot of frustration or impatience with the data. And I think that's totally understandable because honestly, year after year, the data looks a lot the same. So the good news that I've just said is mortality is going down, but incidence is going up, and disparities are stubborn and wicked. And so when we think about health disparities, we have to think really about newer, bolder approaches. And so it's really cool in areas of health and definitely in the cancer sphere to think about the tech, the fancy technologies, the new science, all of those things are incredibly important to hopefully ultimately cures for cancer, to think about cancer genomics. But when we think about those things, genomics and the tech solutions are not the causes of health disparities in the ways that other factors are. What will happen is we'll get the good science, right? We'll know more, and people will still be locked out. They'll still be locked out of accessing care. And so we have to really think boldly about how cancer and other diseases are impacted by the ability to find and afford nutritious food, experiencing discrimination and violence, having safe housing and transportation, access to quality health care with a positive experience of care, to quality education, stable and fairly compensated employment, and leave, an ability to leave your job so that you can get care. Systemic barriers, which are often racialized, mean that there's often a persistent difference in access to high quality care and to the resources that support health. Fortunately, we are learning more about cancer every day. We are working diligently to learn more about how cancer impacts communities in Minnesota, to provide data to guide strategies and funding, to connect Minnesotans to screening and treatment. And so we are getting better. We are learning all the time, and my goal is for the Department of Health to be a learning organization, which is why I encourage you all during the question and answer to really lift up comments, either here in terms of ideas, right? More heads, MDH whole pot of heads, and then all the other heads, like all of us thinking together is better. So lift up ideas, please, in this session. As we have questions, reach out to our MDH team, please, when you have ideas. And I always, and I'm gonna get in trouble with this, brooke.cunningham@state.mn.us is direct to me. Have patience with me. You might have to email me more than once, but if you have an idea, send it to me. I'll send it to the right folk. Because we want to hear from you. We want to listen, and listening is core to addressing health inequities. My goal as commissioner is to make sure all Minnesotans have the opportunity to be as healthy as possible, which really means diving deep into the barriers that underlie those health disparities and by prioritizing community-driven strategies. So, we need to do a deep dive in those factors, those upstream factors, the same attention that we give to sort of basic science, bioengineering, and tech, we've got to give to those upstream factors. And we see a lot of change in our grant making, and indeed, I came to be part of that community advisory committee in part because of what we saw from NCI in terms of what the grants were asking for in terms of community partnership. And people are going further than partnership. They're definitely going further than engagement. The next thing was partnership, but where we are right now is sort of community co-design. So that is the sort of challenge where we are today. And of course, we have to patch our broken system, and MDH stands in that space with our cancer control program, with our SAGE program, and of course, as you all saw, with our response to COVID. Because while we do not deliver care, we often have to be the ones that patch up, come on the back end and provide the Band-Aid to patch the system. So our current strategies, again, partner with you all around the topic of this conference in terms of patient and provider-focused strategies, particularly around screening. So we fund breast and cervical cancer screening for Minnesotans who are uninsured. The SAGE screening program began in 1991 to help keep Minnesotans healthy. It works with clinics and partners across the state to promote screening. It's worked with 480 providers and pays for screening for eligible women. We also partner with providers on implementing best practices for outreach and engagement, as I've just mentioned. And we use data to identify communities and geographic areas that are experiencing lower rates of screening to focus our efforts, right? At the state, we have scarce resources. We need to focus on those who are disproportionately impacted with those resources. And part of the strategy, and part of the strategy that I put out to you all also, is to really think about place-based approaches. So with COVID, we did that with zip code. Many of you all in your work, when you think about community prevalence of cancer, may be using zip code. Zip code is a big marker for those other social scientists in the room. It's often too big. And so one of the conversations that I'm having with my colleagues at MDH is how do we go one level down to neighborhood? How do we define neighborhood when we look at disease incidence and prevalence and then target our strategies to neighborhood? Because as much as we see racial disparities in the data, a lot of what is a racial disparity is often a place-based disparity. And so place is really an effective strategy for operations of any sort of health-based program. It also helps us to not only, for public health, go out, engage community-based organizations associated with communities, but it lets us also ask other questions, like, what is the healthcare access for community members there? Like, Minneapolis may not be considered a health desert just because we're the metro, and if you look at a higher geographical area that HRSA does, we might not come up as a healthcare desert or a oncology desert or a breast cancer screening desert, but I bet you, and I have not looked at this data, so this is a hypothesis, but the face validity I think is high. If you all think about the Twin Cities, there are certain areas that don't have a lot of clinics, that people gotta drive a far distance or catch the bus. And there's certain areas that clinics are just like everywhere, right? And so how do we challenge our healthcare systems and our administrators to really invest in those neighborhoods that need the most support? So when we look at screenings, they've increased over time, but clearly they're still below pre-pandemic levels. And just to share some of the data in terms of the pandemic's impact on screening for Black American Indian women, there was a 98% decrease for breast cancer screenings among American Indian Alaska Natives due to the pandemic, or associated with the pandemic. We can't say due to, causal versus correlation, okay. But associated with the pandemic. We saw an 82% decrease in cervical cancer screening for Black women, and 82% also among Asian and Pacific Islander women. So some of the things that we do at MDH, which I hope you all also do in your settings, in addition to attending to health disparities, in addition to getting under some of those numbers, and one thing I'll just highlight here, I was going to talk about this later, one of our successes with the legislative session is we have a budget proposal to actually disaggregate race data by ethnicity, right? Because multi-generational African Americans like me have different contexts of living, different experiences in this country, so we should not all be grouped, multi-generational African Americans, with newer Black Minnesotans, like Somali Minnesotans. And so in Minnesota, we're gonna think about how do we disaggregate race by ethnicity, right? Like Asian is a huge category. Like, let's stop lumping like all Asian, all API folk together. And so across the state enterprise, we have a project that will create a state data standard, working with the state demographer's office to really disaggregate race by ethnicity, to really set data standards for 2023 gender categories, right? And to also collect disability. One of the things that I did when I came into the department in the assistant commissioner role was ask about disability data, and I got information from Minnesota Community Measurement, and very few, a minority, probably in the teens or 20s of provider organizations collected data on disability status. And so we have to do better and recognize these intersections that contribute to cancer outcomes. So at the Minnesota Department of Health, and sort of in addition to this state enterprise effort to look at data, we also do some fundamental, easy, sort of no-brainer things, right? We have a call center staffed by patient navigators who speak several languages. That is key in Minnesota. Our navigators answer calls and assist Minnesotans with program eligibility. They help navigate barriers, schedule appointments, and provide referrals. Again, as I've mentioned, we work very closely with community clinic linkages. Some of our partners include the Stair Step Foundation, the American Indian Cancer Foundation, Breast Cancer Champions. We work with MINAC, or the Minnesota Association of Community Health Centers, federally qualified health centers, of which my clinic, Kook Clinic, is a part of, to really address and meet those most vulnerable Minnesotans where they are. We support community health workers because we recognize the importance of trusted relationships, right? It is a lot about relationship in healthcare. I really say, right, I'm a primary care doctor, and I think my biggest clinical tool in my toolkit is the relationship that I have with patients. Because when you have a better relationship with patients, they trust you, they listen to your advice in a different way. You come back and you have a very frank conversation about beliefs, about barriers, and they can share things that they might not otherwise share. So my most important tool in my toolkit, more important than my stethoscope, is a relationship that I cultivate with patients. One thing that we know in the equity space is the importance of health navigators, community health workers, and we had another budget proposal to really support the Minnesota Community Health Worker Alliance, and really to look at those models, because we do data. We want to be a resource to the state when it comes to thinking about our health systems of the future. Again, if you all have ideas about what our health systems need to look like for the future, for Minnesotans' well-being, to address cancer and other diseases, please let us know, because just like we study community health workers, we can study other ideas, like can we use interpreters as cultural navigators or cultural brokers in some place, rather than just as folk who come in and translate? Can they come into our meetings when we're thinking about, we're hitting roadblocks? Well, invite folk in who both watch what we do, right, in our exam rooms, but also may have that cultural knowledge that we are looking for and is needed and of low supply in our healthcare systems. The other thing that we do is we look at telehealth, right? Telehealth has been important, particularly when we think about rural health disparities, thinking about telehealth as bridging an access divide, so we clearly have studies to look at telehealth. The other thing to note is that we educate people on things like home-based screening, like FIT tests or fecal immunochemical tests, just because everybody either doesn't want a colonoscopy, or a colonoscopy is particularly difficult. I am due for mine. I work a lot of hours. I don't like the idea of drinking the prep. I am going to do it. But, I got the referral 8 months ago. I haven't scheduled. Y'all can fuss at me. I have a friend who's in the colon cancer disparity space who I duck and dodge his call when I get it. Okay. I need to get it done, but it's not. Bless me. But it's hard for some folks to get a colonoscopy, and so, the FIT test is another good option. And so, again, we have to be in partnership with community, and so we have a number of programs that have done that have really tried to convene a two-way dialogue, to listen to communities, to think about their specific needs and challenges, and to design programs that fit those needs and address those needs, as well as to address stigma and taboo, because cancer is scary, and scary things are often stigmatized. And so we are still mindful of that and have done different projects over time, including a project in 2015, the Pink Shawl Project, created at White Earth as a collaboration between the Minnesota Cancer Alliance. I see some smiles about the Pink Shawl Project, the White Earth Nation, and the Native American Cancer Research Corporation. It provided resources, education, and a safe space to share experiences. Initially, participants were breast cancer survivors who received a pink shawl as a symbol of support and survivorship. And now the group has built off of that and expanded to include all cancers and all survivors, including men. So there are a number of projects, and I'm looking at my time, and we're just going to 10, so I'm going to turn the page. But we have a number of projects that we partner with community. Community is hugely important. I think we should incentivize partnerships with community as much as we can. Part of my input, if Kiara was here, part of my input when I was on the meeting when we looked over those grants was use the levers that you have. So at MDH, our lever is data, right? So grants can be responsive to data. Our lever is the grant itself, right? And so one thing that I've already put out there, and this is the same thing, following on our other grants makers around the country, where's the community engagement in your grant, MDH colleagues, before you send the grant into the feds? MDH colleagues, have you partnered with our Health Equity Bureau, right, to complement that? So the same thing, who are you partnering in an equity space? Have you diversified your partnerships? It's easy to go to the same people over and over. We often can do that across the whole organization. You can do it across all of MDH. You can do it across the university. And we often go to the same people over and over and over again. That creates a particular burden on those organizations, but it's also, we want to be as inclusive as possible so that new ideas, new people, new voices are not systematically, unintentionally locked out. And of course, we've been able to inform policy change. One of the successes was the law that prohibited the use of tanning beds for Minnesotans under the age of 18, resulting in a decrease in tanning bed usage by 73% from 2013 to 2018 when that last data was looked at. And of course, we have a new cancer plan underway, our statewide framework to reduce the burden of cancer, provide health equity in Minnesota, developed by many of the partners in this room, and again, developed through extensive listening. So that is core and that is key, because some of the hardest work that we have to do, we think the work in the lab is particularly hard, but the work with community is also hard. It requires the same sort of time and the same sort of investment. So there are a number of other things that I could lift up. I am mindful of time, so I'm flipping through my pages to see what I want to drop on you. Maybe the last thing I'll speak to are the governor's budget. For anybody interested in health, please do look at the governor's budget. The HHS bill was long. It was my first immersion into the macro and the micro politics, very interesting for a sociologist. I was a participant observer in committee meeting, fascinating. Anyway, so, but like policy levers are particularly important. Showing up at the Capitol is particularly important for those of you all who do. I really want to say thank you for that. That is particularly influential and leaves a lasting mark on legislators more than even I as Commissioner of Health yet to be confirmed Commissioner of Health can do. So please do sort of continue all of your policy work. We know that we had a terrific year for MDH, also for Human Services. So if you get a chance and you want to flip through several pages, you can see what we put out. But if you click Governor's Revised Budget, many of our proposals are there and easier to read than the actual bill itself. But of course, some big successes were paid sick leave, including for caregivers. Again, people have got to be able to take care of themselves, to take care of their loved ones. The child health tax credit, again, trying to help lift folk out of poverty. So we have a budget also that looks at the healthcare workforce. In particular, at MDH, we have a particular focus on our rural healthcare workforce. And so again, seeing all the challenges and sort of access to care, thinking particularly as we talked about cancer and its incidence with aging Minnesotans, thinking about Minnesotans in greater Minnesota who live at a greater distance for healthcare facilities, who are often isolated in the settings in which they live, and actually thinking about workforce strategies to make sure that they have the access to care. I think I'm gonna quit, and I'm just gonna say we are really happy to continue to work with all of you all. We have 15 minutes left, which was about the time I was supposed to leave for questions, so I'm gonna end. I thank you all for you all's attention. Thank you for helping to address cancer in Minnesota. Thank you for having me, and look forward to your questions.
Thank you for the great talk. I just wanted to ask, so you mentioned that it would be good to have interpreters play a more central role in patient navigation, which would be key, right, to expanding healthcare access. I'm curious how you could maybe envision patient navigators being more essentially part of the core medical team and follow patients to make sure they are able to complete what needs to happen. Fit tests are very useful, but if you have a positive fit test, you still need that colonoscopy,
right.
So you're still gonna need some help. So how are we gonna make sure that these navigators can be more integrated?
Right, now I think being explicit about, we want people to quote unquote, practice at the top of their license, right? That's a saying that we have in medicine. And what happens is that people have a lot of skills that get underutilized, right? Even me as an internal medicine trained primary care physician. And I would say the same thing for many of the individuals who now currently serve as interpreters. And so when we think about some of our workforce shortages, this session, we're talking about physicians, dentists, to some extent, right, community health workers. There hasn't been a sustained imagination, so we have to boldly imagine the role that interpreters can serve, and recognize that while they have a skill set that is under-tapped, we have a lot of the same workforce challenges. So how can they participate more in community care navigation? How can they participate more in providing input into health system operations? It will be difficult to do that if they, like me, go from patient to patient to patient to patient, and there are staff shortages, right? And so we have to also think about how do we open up those pathways into interpretation as a field, but also be creative and bold and partner with the interpreter workforce about the skill set that is under-tapped and underutilized. Hi, Abby.
Good morning. Hi, Dr. Cunningham. Thank you for your inspiring talk this morning. Is there a relationship, or what is the relationship between Minnesota Community Measurement and MDH? You mentioned that earlier. I wasn't aware there was a relationship.
Yeah, thank you. So data is incredibly important. Let me back up just a little bit before I talk about that group specifically and talk about what we're seeing nationally. Part of closing care gaps and part of providing high quality care is making sure at the bedside people have the information that they need to take care of patients, and also so that patients don't have to get the same test that they just had down the street, but you can't access it. And clearly with tech companies like Epic and Care Everywhere, that gets facilitated. But nationally, at a national level, what is happening, of course, is the federal government, the Office of the National Coordinator for Health Information Technology, is really thinking about not only investing in state health information exchanges, and what we used in COVID was not a health information exchange, it was our Electronic Health Record Consortium, which is a number of healthcare systems across the state that came together to help us with COVID incidence and prevalence and data. But what we are seeing nationally is an increased reliance on health informatics, not only for clinical care, but for public health data. So all of our, so many states are using their health information exchanges. We are not yet doing that in this way, but really for the public health data, whether it's like a new infectious disease, but it could be also chronic disease incidence and management, or things that relate with cancer. So all of this is developing now, and so I'm sharing that because I see that on the national landscape as the future. And so I would also encourage folk out here, as if there are any data scientists in here or informaticists in here, to also think about what are the opportunities, because big data is the future. I'm a mixed methods, qualitative, a little bit of regression researcher, right? But big data science is the wave of the future. So Minnesota Community Measurement, as you all know, provides sort of screening data, how much is controlled for a number of disease metrics, diabetes, asthma, and they are a partnership with healthcare on the healthcare side, just like the Electronic Health Record Consortium. And so we partner with them, but it is a transactional relationship as well, so to look at that data. But they are long-standing, as you know, invested on the healthcare side. But one of the challenges that we have as public health is thinking about what is happening nationally in terms of health system clinical data, which everything that I can see when I look at the landscape and look at the future is that we are going to use that clinical data. So that would be the other thing for public health. Y'all can help me in your spaces if you are members of provider organizations, is to really think about how do we weave in like social determinants of health in a robust way into that data, because that data, I do believe, is the data of the future. So Minnesota Community Measurement currently gets reports from clinics and systems. This data will be real-time data and will cover a lot of the population. And so, again, we'll have to see how that shakes out nationally and what the relationship will be in our Minnesota landscape between Minnesota Community Measurement, the Electronic Health Record Consortium, which continues to go strong. It was really an asset for us for the pandemic. And then all of these investments from the Office of the National Coordinator for IT. So informatics is a big deal, and so if there are any cancer informaticists in our audience, I would love to talk to you because I'm learning this space. But I want to make sure public health in partnership with our Department of Human Services are also ready for this source of data, because it's not just gonna be clinical data, it's probably gonna also be like your credit card data, like where you actually shopped, right? Like big data on one hand covers so much of the way we live our lives that it becomes scary and uncomfortable, and at the same time, it is going to be where we move as the years pass. Thank you.
I love big data too, but I am a little concerned sometimes about what we miss in the data. And as this coalition is looking forward to revise our state cancer plan, do you have any suggestions about things we could do to make sure we capture the community perspective and voices and really amplify not only rural perspectives and BIPOC perspectives, but especially cancer survivors and caregivers?
No, thank you so much. And I think that is, I mean, this is why you have to balance, of course, and this is probably what underlies part of your question. You have to balance all of the quantitative, the stuff that is like almost you can't even see the people behind those numbers, which is a risk for any space of population health, is you can kind of lose the people sometime. So how do we get to the people? And so I think we have to be deliberate. We have to put carrots and sticks in there and expectations, which is why I call on anybody who gives grants to do that. And then we have to also, in a bigger sense within our organizations, because many of our organizations are not just cancer, but touch community in many other ways. And part of, I mentioned environmental health and cancer, right? I mentioned our health equity group and cancer, right? The list can go on and on. There are other programs within the Department of Health that partner with SAGE. So we also have to break up silos as we reach out to community. That will make our reaching out more impactful, right? Because people are concerned with multiple aspects of their lives, and it will make our reach out more efficient, and will allow us also perhaps to braid funding streams together to create that impact and that incentive. And so to the extent that we can get community voice, and again, I think it goes back to relationship. And the other thing that I used to share, and this is what I tell folk, I tell people, people at MDH, I think y'all have heard me say this out of town hall. I just tell it, right? I just tell it. And so when I was on the internal cancer team, I asked for our grants. Like, let's use our grants. Let's weave our data into that, and let's create expectations even for our basic scientists. Right? For me, it would be like, Epi team, you got to go out and talk about, fancy epidemiology in the community. I would say basic science, lab team, right? What does your community dissemination and co-design, as you even think about the most molecular science, look like? So, thank you. I see one more question here.
Thank you very much. I have a question specific to disability, and you mentioned a quote, less than 10% of, I'm not sure.
Somewhere in the teens or 20s of provider organizations from Minnesota Community Measurement had captured any sort of disability data. I don't know what type standing up here, but sort of any sort in their systems when I looked at it.
Because I know there's a lot of talk about, and appropriately, about racism and sexism and gender, but disability does seem to be lost in the topic of ableism. And so you also mentioned that there are two levers at MDH with data and grants. So if you're already dealing with a group of people who are not captured, it kind of confounds the problem. So maybe a statement or a question, how can the MDH better interact with, for example, people who are deaf or hard of hearing?
Yeah, thank you. So the first thing, like you said, is to try to figure out what the right categories are, and clearly at a national level, this is, as most things are, they're not Minnesota specific. So nationally, people are looking at what should data standards be around disability data collection and standards. And so we have to track that national conversation. We have to incentivize where we get the data from. So if it's Minnesota Community Measurement or our healthcare systems, they need to be incentivized. So MDH is important for us to do it at the state, right? But our partners have to do it too, because we rely on their data, right? And to make sure that we have the right categories, there will be some trade-offs as the conversation develops, I can imagine. But we need to, the ideal thing is to vet categories by communities most affected, right? And so that would be the other thing for us to do. And then use those levers as you're thinking about any area of health, cancer or otherwise, to perhaps produce grant opportunities, incentives for people to pay attention to the intersections between ability and disease incidence, prevalence, and outcomes. So again, we do have to get the data first. We have to engage with communities to listen and to learn. We have to move the levers in our healthcare system around data, as well as around other aspects that impact the quality and experience of care. And again, we have to incentivize everybody to be at the table, to make it easy and then create the incentives, because again, it is, and the reason I say like teens to 20s, because I don't want to shortchange healthcare for not collecting the data. But that is a big gap that has not been attended to.
Everybody, thank you all for being here. If you want to tweet, please use MNCancer, @MNCancer as a handle, and please tweet away anything you want to from the summit. Thank you.
And thank you, Dr. Cunningham. That was so inspiring to see how you're leading the state, how that links into national and global efforts too. You can see your passion, and we are so thankful for your dedication to our community in Minnesota. A round of applause for Dr. Cunningham.
Thank you, and thank you all. Thank you.